You're watching a protected PCI.com video.
Thank you for joining us today. He is the president of our society, the Society of Catheterization, Angiography, and Intervention. I'm a proud card-carrying member of our union, and I thank you so much for the enormous amount of work that SCAI does for all of us, from whether it's radiation safety to talking in Washington and advocating for us. So I'm honored to have you as part of this program. Shami?
Great. Thank you very much, Bill, and it's an honor to be here. Just one word about SCAI. If you're not a member, we've got over 5,000 members. We're in over 70 countries, and as Bill pointed out, it is the only organization that truly represents the interventional cardiovascular specialists. So I would strongly encourage all of you to apply and get more involved and engaged. We've just been hearing about the benefits of complete revascularization. You've heard both talks highlighting not only how important it is to completely revascularize the patient, but I also feel for us as interventional cardiologists, if we're going to tackle complex disease, multivessel disease, left ventricular dysfunction, and achieve outcomes that are comparable to bypass surgery, we need to improve our game, and that's really the core message here. So let's look at when we are able to achieve complete revascularization, what effects does it have on EF and patient symptomatic status. And keep in mind, we're always talking about bypass surgery for multivessel disease as the gold standard, because compared to medical therapy in data that's 30 to 40 years old, what did we see? We saw improvement in mortality and we saw improvement in LV function. So with that background in mind, let me show you how we're doing today in the interventional world. We're doing just under 1 million PCIs in the United States annually. We're probably not treating, based on some of these data, on the left lower box there, 320,000 patients or so who have heart failure, coronary disease, for various reasons are not undergoing revascularization. But let me look at and focus on the PCIs that we're actually doing. How often are we achieving complete revascularization, or flip the question, how often do we have incomplete revascularization in the patients who have left main or multivessel disease? That component is about 1/4 of all PCIs, and amongst those, we have about 100,000 or so patients who have incomplete revascularization. So 45% of patients who have multivessel disease or unprotected left main are not currently getting complete revascularization. In a cath lab that does about 600 PCIs a year, that would be 63 patients. What about the proportion of patients that we're staging? We're staging a large portion of patients, and a conservative estimate would be about 134,000. So again, going back to an average lab doing 600 PCIs a year, 84 patients are being staged, and Rod showed you data earlier that sometimes staging is harmful, whether that's because patients have events while they're waiting for their staged procedure, or they never come back for complete their revascularization as they get staged. It's unclear. Patients who suffer acute kidney injury associated with PCI, 7% of all patients undergoing PCI, so 42 in a typical lab of 600 PCIs a year. But the high-risk PCI patients, the ones who might have multivessel disease, baseline CKD, that risk is significantly greater. And if you do go on to develop AKI, acute kidney injury, or worse of all, if you go on to develop hemodialysis, which is about 1 to 2% of patients in the NCDR with complex baseline anatomy, then you have a much, much higher risk of overall mortality. Once you've undergone PCI, look at the portion of patients who continue to get readmitted to the hospital. Between 8 to 17% get readmitted for cardiovascular reasons. 25% of all patients undergoing PCI get readmitted within 6 months. Now that's a combination of cardiac and non-cardiac reasons. And so we are dealing with a complex set of patients, and if they come in with an acute coronary syndrome, which approximates almost half of the PCIs done in the country, 20% of them get readmitted within 30 days. The most common reason for readmission is a repeat revascularization that's required. And finally, the portion of patients who have some form of cardiogenic or non-cardiogenic shock, 165,000 out of the 955,000. So 1 out of 6 patients undergoing PCI in a typical cath lab. So when we look at the landscape of contemporary PCI, we're looking at a large portion of the population that has complex disease, complex comorbidities, and how can we get better outcomes? That's in these patients, and that's really the focus for all of us. These patients often don't have an AUC issue. So if you're going to revascularize these patients in the cath lab percutaneously, they have class 3 or 4 anginal symptoms or heart failure symptoms, which means that if they have multivessel disease or prox-LAD involvement, anytime you undertake a percutaneous revascularization strategy in these patients, it is appropriate. I hinted at this earlier. We know that with bypass surgery, if you have left ventricular dysfunction and you revascularize those patients, you get improvement in ejection fraction. Older data, but consistent from 2 different studies. Dr. Popma went over the PROTECT 2 trial in incredible detail, but I will highlight a couple of things. This has been shown earlier. Focus on the right side. If you have multivessel disease, 2 or 3 vessel disease, and you get revascularized with Impella hemodynamic support versus balloon pump support, the degree of revascularization, and Jeff touched on that, the myocardial jeopardy score improvement is similar between the 2 strategies, and yet the patients who had hemodynamic support with Impella had better outcomes at 90 days. EF improved from 27 to 33%, 6% EF improvement, and this was matched or supported with concomitant reduction in symptoms, i.e. the portion of patients with class 3 or 4 heart failure symptoms reduced from almost 70% to under 30%. This study is a retrospective look of 86 CHIP patients treated over almost 9 or 10 years at 2 centers in Italy. If you look at the group of patients, very, very high proportion of patients with low ejection fraction, only 22% had an EF of greater than 35%. So most patients with EF under 35%, and at 6-month follow-up, what you see is that the vast majority, 67%, has EF improvement of greater than 35%. So this is not in hospital or at hospital discharge, but at long-term follow-up. Looking at a series of trials from the US Pella Registry, PROTECT 1 on the left side, PROTECT 2 and the Roma Verona Registry I just talked about on the right side, I really think the focus should be on the right side. If you look at between baseline and hospital discharge in the US Pella Registry, you see a 5% EF improvement, but we don't expect EF to improve within 24 or 48 hours of revascularization. Hibernating myocardium takes days to weeks to recover, and if you look at 90 days or 180-day follow-up on the right side, you see that the ejection fraction improves from 6 to 8%. And let me finish up with introducing an exciting new study that's just been launched. It's called the Restore EF study. It's a multi-center, single-arm prospective clinical study. These will be patients who will be treated with Impella placement, high-risk PCI, 30 centers with the goal of enrolling at least 500 patients. Patients will have EF at 90-day follow-up. Cardiogenic shock and active STEMIs will be excluded. And there will be a number of exploratory pre-specified analyses that are being, the questions that will be answered as a part of this study. One of the ones that is very important to me personally is I really want to figure out whether or not baseline myocardial viability is predictive of improvement in outcomes, or is this not of particular value. So centers that will have baseline viability measures will be enrolled as well. These are the centers that are participating in this study. And the goal is to take experienced operators doing at least 300 PCIs on average a year, at centers doing 700 PCIs a year, who are very comfortable and adept at treating patients with multivessel, unprotected left main, using concomitant atherectomy as needed, so that we can find out when you have experienced, well-trained operators who can achieve complete revascularization, can we then translate that to improvement in clinical symptomatology in these very sick patients in 2019 and beyond. So it's a contemporary trial with the first patient having been enrolled earlier this month, and we're hopeful that over the next few months we're able to complete enrollment, and then start to answer these questions in very, very complex disease patients. So I'd like to finish with reminding everybody that it's imperative that in the contemporary PCI era, all of us who do PCI improve our game. We really need to be able to tackle complex PCI well. We need to get the skill sets in all of our hands, because that will translate into less AKI at the time of complex PCI and improvement in ejection fraction in patients who have multivessel disease. And that way we can tackle the very complex diseased patients who are often the ones who get turned down by CT surgery. Series of studies, PROTECT 1, 2, PROTECT 3 that you just saw the data from, have all shown that with Impella placement and complete revascularization, or as much as possible multivessel revascularization, EF improves, heart failure symptoms improve, and we will be able to see how the RESTORE EF study can shed further light on this in contemporary interventional cardiology. Thank you.
You've been watching a protected PCI.com video.